Dr. Soran, welcome to our podcast. I'm very happy to have this special episode with you because you have some very unique specialties in the field of medicine. But before we get into those details, I would like to know, when did you first leave Kurdistan and go to the UK? Did you go to study?
Thank you very much for having me. I'm very grateful and I'm delighted to visit my country, Kurdistan, and to be in our capital, Hawler. I left Kurdistan to United Kingdom in 1990, end of 95, and I reached UK in 1996. And like many others at that time, I left with the ambition of studying, developing myself, and to do something that will help Kurdistan and Kurds in the future. And like many others at that time, the only way to reach Europe or UK is by going there and claiming asylum. So no secret, I was an asylum seeker in United Kingdom. I arrived in 96 and I claimed asylum, and that was approved.
Nice.
And I'm here today and in Kurdistan. I visit Kurdistan regularly 2 or 3 times per year, and I still feel this is my country.
So you went with the ambition, as you said, or idea of studying. Did you know what you wanted to study, or there you decided to study medicine
I finished medical school here
first?
first, in Baghdad, and then I worked for a short time in Kurdistan. I was a master's degree student in Hawler before I leave. And I had a very clear vision and ambition. What do I want to study? I wanted medicine. And then I had an idea. I was between 2 or 3 specialties. And when I reached UK and started work in UK, I finalized my specialty and then later my subspecialty.
Were you able to start studying there right away, or did it take some time before you could get in to continue your studies?
Yeah. When you arrive in UK, the system is that you need to pass certain assessments, including a language assessment and then a medical assessment. And then they recognize your degree, register you in General Medical Council. And after that, you can apply for jobs. So there you work and clinical training. You work and you take your exams and you do your assessments with your clinical work and your clinical training. It's all integrated. You have supervisors. So you work, you earn money. At the same time, your employer will give you some time to, we call it study leave, to attend courses, to study, to take exams. And then you take the exams one by one. So and we'll can discuss it later, but there are 2 tracks of training there. You can choose one or another, or you can choose both. There is a clinical training where you take you basically you requalify there with an exam called a language exam. Used to be called IELTS, but now it's called something else. And a clinical exam called PLAB. And then you take, in medicine, you take MRCP 1, MRCP 2, and then after that, you choose your specialty. You enter a training program of 5 years. That's general medicine, and then you do another 5 years to subspecialize. For myself, it was subspecialization in endocrinology, diabetes, and metabolism.
Wow! And everyone who goes to the UK to study has to go through one of these 2 tracks.
If you want to progress and take a leadership role or a consultant or an academic role, you have to do one of these 2 tracks, either the clinical one, which I described, and then at the end of the 5 years of the clinical one, you have yearly assessments, and at the end or before the end, you take an exam. We call it the certificate of specialization. CCST. You take this exam, you pass this exam as well, and then you are eligible to apply for consultant posts.
So if someone goes from Kurdistan to the UK, they have a medical degree, for example, they are a doctor. Will they be able to practice right away, or do you have to go through some process?
No, you have
If
to.
they don't want to study, for example, they say, I have no time, I have 15 years of experience. Does that work there or no?
The standard path is you take the language exam and then you take the PLAB. You are registered with the General Medical Council, which is equivalent to Sendika Pizishki in Kurdistan.
The doctor's syndicate.
So doctor syndicate.
Mm.
And then you apply for jobs. Sometimes there are exemptions. You can enter the system. You can enter the system with Royal College of Physicians sponsorship, but in 99% of the cases, you still need to take this exam, PLAB and language exam, especially if you reach there soon after your qualification or within few years after your qualification from medical school.
So, when you got there, you went from Kurdistan in 95, you got there in 96, you said. Kurdistan was very different back then. How was the difference that you found when you arrived in the UK in terms of universities, the whole medical atmosphere in the UK? Was it shocking? Was it the same? Was it very different?
Yeah. So can I just take you a step back to explain the second track of training? So what I described is clinical training. You become a consultant. And there is a second track, which is academic training. And for this, you need to do a master's degree and then an MD degree. We call it medical doctorate. This is only for doctors, medically qualified doctors, or you can choose to do a PhD or MPhil. So in parallel, I entered both of the training.
Wow.
So I finished all of the clinical ones, which is multiple exams, and I did an MSc. Then I became a consultant, and then I did an MD, medical doctorate. After that, I finished it in 2011, and then 2011, yes, and then I established my own research team and started from scratch with the help of my supervisor, MD supervisor, Professor Paul Darrington, who was a very good mentor. And I established my my research team as well.
Why did you do that research team?
Yeah, so there were a choice of concentrating on clinical and building up a private practice. I do private practice, but only half a day a week or something like this, or at most a day a week. But if you focus on private practice after you become a consultant, financially, you will be much better off.
Yeah, so but it was your personal project, basically.
Yeah, it was, but I chose to develop an academic career. And the main reason is in academia, I wanted to perform, I wanted to succeed, and I wanted everyone, if I succeed, I wanted them to know I'm a Kurd and I'm from Kurdistan. And the main reason why I chose the academic path rather than building up a private practice or private clinic, the main reason was because I wanted really to make a name for where I belong to, which is Kurdistan. And all of my students, my team, in the societies, any society that I play a role, they all know who I am, where I am from, and where I came from. So that's the main reason why I selected the academic path in parallel.
Academic path meaning instead of medical practice, you do teaching and training of other doctors, or what does it involve exactly?
Yes, it involves teaching and training of clinical trainees. It's with a clinical path, but doing research and supervising MSc, MD, and PhDs, doing a lot of research, that's within the academic path, and publishing papers.
Nice.
So that's with the academic path, presenting in conferences. You become a leader in your field nationally and internationally. this can be only achieved via the academic path, and making a name for yourself, to be recognized as one of the experts in your field, one of the expert centers in the field. So all of this you achieve it uh, uh, mostly through the academic path.
Mhm. And then going back to that topic, you have achieved all of those things. You went there, you went into the 2 tracks of training, you finished the different stages of your studies and qualifications, and it must have been like a welcoming environment for you to be able to go from Kurdistan or the Middle East, let's say, and find yourself in a place where you could do all those things, and in the end also form or establish your own research team.
Yeah.
So the question that I was saying, how was it when you went from the early 90s? Kurdistan and Iraq in general was not like what it is now. What was the difference like when you got there?
So when I got there, uh, it was challenging, and I think any doctor who goes from here to UK and manages to practice and to attain these requalification degrees, it's a big success. Only this is a big success because it's not easy, it's challenging. And I worked 6 months after I passed my PLAB uh, for nothing. We call it honorary posts. I worked it for nothing because I wanted to start in a teaching hospital. So I worked for I was in that teaching hospital for almost 6 months. I was just doing shifts to make sure I can make enough money to live. But to enter the system via a good hospital, a university hospital, I chose to do 6 months unpaid. But then after that, the first job came up. They gave it to me, and then I started from there. And every single step there, it's challenging because you go from abroad, from Kurdistan, for example, and you're a few years behind those who qualified there.
In what sense? Scientifically or?
No, in terms of career progress.
Mhm.
Because, for example, people who qualified in the same year, say people who qualified in 94, 93, by the time you go there, you wasted some time, and then you re-qualified, you waste that some time, you waste some more time.
Mm.
It's not a waste, but you are not working. So they are in their clinical training career, they're a few years ahead of you. So finding the job is a challenge because you have no experience. You apply, they always prefer people who have experience within the system.
Exactly.
And then to catch up with these people and to compete with them, it's another challenge. And you need really to work very, very hard to be able to compete with them.
Exactly, yeah.
And so I always say, especially after I got married and my wife Tara and my 2 kids Ciara and Zara, I always say I'm very grateful for them because the time I invested in all of these is basically meant that I was with them less.
Mm.
Yeah, and of course I also like to acknowledge my mother. My father passed away, but my mother, who was always asking me, when are you going to become a professor? I said, it's too soon. It's too soon. Just give me some
Wow.
more time.
Your family was here, your mother and your parents were here while you went to the
Yeah, I went there first, and then the rest of my family joined.
Mm. Yeah, it's good that they stood behind you while you were pursuing your own
Yeah,
path.
exactly. Yeah, and they did. And if after marriage, my wife Tara, and also my kids, they all appreciated, and they they stood behind me. And my kids still, they say, why do you work so hard? And I say, it's important to make a name for yourself and also to make the name uh, uh, for the, the place you belong to.
Yeah.
It's very important as kids, we need to try our best to show the world and everyone that we can do everything everyone else can do. We just need the opportunity.
Exactly. And often when someone migrates to another country or goes to another country to pursue studies or something, they will find someone from their own country, let's say another Kurd who has been in the UK for a number of years, that would become your mentor or help you in the early days. Did you find someone who helped you? Any Kurdish doctor or someone in the medical field that did help you in any way, or you were looking up to, or you did it all on your own?
Um, I basically there were one doctor I have to acknowledge. He's now retired, Dr. Fuad Hanari. Uh, he had a small organization to guide and help these young doctors who arrive. So some relatives directed me to him, and I contacted him. And initially, he gave me some advice and some support from the organization they established. And then after that, you have to look for yourself, and you have to find your path
Exactly.
on your own. And I have to acknowledge a few other consultants and professors who supported me in my early days. Dr. Paul Miller from South Manchester University Hospital, Professor Peter Warwell from the same institution. In my early years, they were very supportive. Dr. Holmes also initially, and I have I have a very good memory. I mean, with him, especially when I was trying to educate or explain to him why the situation in Iraq, etc. And there is a joke about it I can tell you later. But Dr. Holm was very supportive. So on the other side, you come across people who basically they are not so supportive, or for one reason or another, they in these days it was really not that strange or illegal to tell a doctor, well, we haven't appointed you in the job because we have a local candidate, even if you are better. Now all of these are regulated better, but there are, everyone there also come across challenges and difficulties. But for me, anyone challenges you or makes your life difficult, you just put it behind yourself. You use it as a as a as something to push you forward to achieve more and to prove that
You won't let it stop you.
Exactly. And you acknowledge people who supported you, the names I mentioned. And later in my MSc, Professor Jeffrey Gill in Liverpool University, and also, of course, Professor Paul Darrington, Manchester University, who was my mentor in my medical doctorate, and he supported me hugely. I'm very grateful for this man. And there are many other people who were supportive. And what's really nice, some of my PhD students and my trainees now they are consultants and
In the UK.
In the UK, yeah, and they are very. They acknowledge all the support I gave them. Now they are very supportive.
Nice. And for years, like for decades, people in Kurdistan and Iraq, in this area generally, they admire many things British. They go there to study medicine, to study political science or different fields. So when you got there and you got into the system, was it what you had expected? Was it a good field? Like, did you realize that this is the right place to continue your studies, as people have been doing for decades?
Yeah, it is the right place to continue your studies, especially at that time, because
In
there's
medicine.
in mid 90s, because there is a huge difference. The system is good for it is the NHS system, National Health Service system. It's the most cost-effective system in the world, and it's the most tightly regulated system. What I like in NHS, for example, is if the patient needs something, you don't do it, you are responsible. If the patient doesn't need something, or a medication or a procedure, if you don't do it, you are responsible. So you have to do the right thing.
Wow. In both cases.
In both cases, regardless of what is in it for you financially or in any other way.
Yes.
So if you perform extra procedures because you benefit from it financially, for example, in a private practice, then you might be questioned.
In the private practice, you are not allowed to do it, or only within NHS?
In both.
Mm.
We have something called GCP, Good Medical Practice Code, and General Medical Council advice. So you have to do the right thing for the patient as much as uh, uh, per your knowledge
Mm.
and per standards. If you are not sure, you have to discuss it with your colleagues in multidisciplinary teams to make sure you take the right decision for this case if it's difficult. So if you do a procedure for a patient which is not necessary or if you do a test or something which you can't justify, then this is not a good medical practice and you can be questioned.
Mm.
Yeah, so that's the nice thing about UK system. And it's the most cost-effective system in the world. For example, per head in UK, in US, United States, per head they spend 3 times on healthcare compared to UK.
And yet they might not get the same health
It's
service to people as in
it's
Europe
not
or UK.
Yeah, in US it's all based on insurance. It's not free.
Yes.
In UK, it's free at the point of delivery.
Mhm.
So all the basics and even any treatment, you get it for free, but sometimes there is a waiting list.
I remember the first time I went to the US to study, I went to a doctor for something, and then he prescribed a pill. And he said, "Do you have insurance?" I had insurance, but I said, "I'm not going to go to get through the referrals and things. I'm going to buy it myself." I thought it was like Kurdistan. So I went to the pharmacy, and it was costing me more than $100, a few pills. So I quickly called my university insurance company. That was my first cultural shock, as they say, with the medical system.
Yeah, no, in UK, if you are a UK citizen and if you live in UK and you're entitled to NHS prescription per item, you just pay. I think now it's £9 or just above £9 per item prescribed.
And then that's it, or the government pays the rest, or it's just £9?
Government pays the rest.
Co-pay. So I was going to mention you mentioned the topic of how much the US spends on healthcare per head versus the UK. I've read in some books and places that like wise governments in some parts of the world, especially in Singapore, I heard in Japan and South Korea, they try to have a healthy society. So they invest in the health of members of their society so that it costs them less later in treating them. So that's a bit. Do you agree with that? That I think in many countries people have a very unhealthy lifestyle, and later it becomes a heavy burden on the health system.
Yeah, absolutely. And this should be the right choice. I think there is a Chinese proverb which says, a good doctor prevents the disease, a mediocre doctor treats the disease.
Exactly.
So, and this is exactly what we are trying. In my specialty, in cardiovascular risk management and preventing atherosclerosis, which is one of my subspecialties, we focus a lot on preventing disease and preventing events because eventually that will save the system. That will save a lot of money for the system. And
Yes.
you're absolutely right. You're spot on.
Having a healthy citizen is better than spending a lot of money or from the federal budget, right, on that person.
Yes, exactly. And we are, to a good extent, we are successful. But for example, with smoking, the smoking is much less in the newer generation. That the government is trying hard. One area which we still fail in is obesity and physical exercise. With this one, we don't have any success as yet because prevalence of obesity is still on the rise in UK and in many other countries. But you're absolutely right. We should try to prevent rather than treat.
And do you know what's or let's say, did you have any experience in the healthcare system in Kurdistan before you went? Because you had graduated already. Did you work to get a sense of how it works here before you went?
Yeah, before, uh, yeah, I did, and it was difficult times with double embargoes from Saddam Hussein, and so uh, when I went there, what was nice in UK, you practice medicine as per the book or as per the latest evidence. We didn't have that facility in Kurdistan, even in Iraq in mid-90s. But now the pace of development and the service availabilities and skills of doctors in Kurdistan uh, is basically developed very rapidly, and the gap has narrowed.
Here.
The gap has narrowed. What you can get, what you could have got then in mid-90s, it was between here and there in UK, it was very wide. But now the gap is much narrowed. Some areas in Kurdistan developed faster, some areas still developing, some areas needs more attention.
So the area of the area of healthcare has developed, do you think?
In Kurdistan, it's over the last 20 or 25 years, yeah, it's developed, and there are a lot of facilities, doctors' knowledge. There are a lot of facilities, a lot of newer services, techniques are used here. Many of them are available, same as abroad. Knowledge is developed. The internet opened a lot of opportunities for doctors to follow the development. Also, the borders has opened. Doctors here are coming to UK for conferences, for meetings. We come to here, we run conferences, we arrange conferences. All of these helps to exchange knowledge and to learn from each other. And that help the system and help the healthcare professionals in Kurdistan and also the patients.
Exactly. Kurdistan is no longer as isolated as it used to be when you went to the UK in the early 80s, or even the 80s or 90s. We were isolated, as you said, double Iraqi embargo on Kurdistan and the international embargo on Iraq. Now this opening up has helped.
Yeah, exactly. And I always, as a joke, I say one difference also I noticed. I used to work in Razgari Teaching Hospital here in Hawler before I leave. And when my first opportunity to do some supervised work was in a hospital, Withington or South Manchester University Hospital. And the building, one shock for me, when I went, I looked at the building. The building was built in 1910, 1920, so it was a very old building.
Wow.
And when I compared that building to Razgari Teaching Hospital, I said, wow, Razgari Teaching Hospital building was much more modern. But when you enter the building and you see what they do in the building was cutting edge of science and medicine, and it was all up to date.
So it's historical architecture with the latest sciences and technological advancement.
Yeah.
There is another thing I would like to discuss with you, and it's that I saw there is a famous Kurdish doctor here. I don't know if I want to mention her name or not, but in many TV programs, she complains that when you walk on a street, the doctor's street in Erbil or Suleimania, and these signs on private clinics, the doctor has given himself or herself many titles. I studied this in the UK, this and that. And she says that it will take you years and years to achieve each one of those titles. She complains that some people go to the UK or Germany for a week or for a workshop. They come back, they put it on their sign outside the clinic. What do you think of that? That some doctors may do that?
If they do, I cannot say they do or they don't because I haven't read all of these doctors.
I haven't. Go to the city center later.
I will do after this this podcast. But doctors have to be basically honest. There are degrees, there are qualifications, and there are courses and workshops.
And certificates.
And
probably.
certificates.
Yeah.
Certificates, you can, if it is acknowledged, and it's, for example, in our specialty in UK in general, you train 5 to 6 years to get certificate in, for example, in diabetes endocrinology metabolism or in gastroenterology. That's 5
That's
years
a real one.
clinical training,
Exactly.
followed by yearly assessment and a final assessment and exam. That's called still a certificate, but it is, for example, it's a certificate, it's a degree that's higher than MRCP or FRCP or FRCS or anything else, because it's more intensive, more specialized. But you attend a course for 3 days and they give you a certificate of attendance to, for example, European Society for Cardiology. You attend 3-4 years and you get a certificate of attendance. That's not a qualification.
Yeah, that's what she means. I think that doctor,
Yeah.
she says a 3-day training.
That's not a
And her point is that it will deceive the patient by seeing that on your board. They might walk in and seek your advice because it's on your board, while it has been only a 2-day workshop or something.
Yeah, exactly. So that's a very good point. You have to be honest, and I think that should be regulated. And there are some society memberships. One of the societies, for example, Royal Society of Medicine, in which I was up until 7-8 years. I was the president of the vascular lipid section. I cannot put that as a qualification.
Why?
I am a member of the society. I was the president of it. I'll put it in my CV as a position that I hold, the same way if I am managing a hospital. But this is not a qualification. And Royal Society for Medicine, for example, it says where if you are a member, you cannot put it as a qualification. This is different from member of Royal College of Physicians or fellow of Royal College of Physicians. These are qualifications. But member of Royal Society of Medicine, member of, for example, Heart UK, member of European Association of Study of Diabetes, or any similar things, American College of Cardiology, you are a member. This is not a qualification. And only medics themselves can basically assess and decide this. The general public wouldn't know. So it is your job as a medic, as a consultant, to basically be honest with yourselves, with the public, with your patients, and you should put only real qualifications on
Which
your
you could practice.
Exactly. Being a member of various societies, etc. For example, being a member of Medical Syndicate of Kurdistan, it's not a qualification. You're a member of a syndicate that allow you to practice.
Yeah,
A member,
it's an acknowledgement of your
Exactly.
degree or something.
Yeah, for example, being a member or a registration with General Medical Council, this is not a qualifications. This is similar to being a member of Syndicate of Kurdistan. But being a member of Royal College of Physicians, this is a qualifications because you need to do some training, at least 2 years, and then you take an exam, part 1, then part 2, part 3. This is a qualification. So doctors has to be like anyone else. We have to be honest. We
More honest probably than most other
Exactly.
professions, because they're
Exactly.
dealing with people's
Yeah.
health and life.
Exactly. And we should be more regulated and more disciplined compared to any other specialties. And this is the case in UK. Doctors is the General Medical Council, which is equivalent to syndicate in Kurdistan. It has its own court.
Yes.
Its own court. Medical negligence and anything relates to medical practice will end first in General Medical Councils and their regulatory body, and what's equivalent to court first. So it's very well regulated, and we have to be honest. And if what you mentioned is practice, it is not appropriate. We have to stop doing these things.
Exactly. And you said that you come back at least 2 or 3 times a year to organize conferences and meetings with. So you must have some kind of idea of the healthcare in general in the Kurdistan region. What do you think are its defects or areas of improvement that should be done in the healthcare system in the Kurdistan region, if there are a couple points that you have noticed?
Yeah, I mean, first of all, the system has developed. Knowledge is much, much better. Services, whether in private hospitals or public hospitals, is much, much better. The service patients can get is better, but we can make it even better. So it has developed a lot, and the pace is very fast. But what I basically, sometimes I come to Kurdistan and there is a meeting or big meeting. They bring, for example, a company from country X who will join with Ministry of Y, and they develop the service to a level that we dream of. And years after, nothing happens. And I attended few meetings like this in Kurdistan where they claim partnership with a company or an authority abroad that they come and they develop our services, the government services. But sadly, I didn't see any changes based on these meetings on the ground, based on these meetings I attended. What is really good, and that what people they do, for example, in NHS, we need to first assess what resources we have.
Exactly.
And then we assess what financial support is available based on the resources, qualifications, and then we plan what can we develop and prioritize the areas we need to develop. And this is how it's done in NHS. And we need some areas, for example, in my opinion, which needs further development is probably acute care. We need to probably develop it a bit better because some of the elective care, like elective surgery, elective medical care, developed faster compared with acute care, for example.
Can you give us some examples of what is acute care? What does it involve?
Yeah. Acute care involves admission because of emergencies. Yeah, so any medical or surgical, gynecology or pediatric emergency, you're admitted to hospital. That's called acute care. Anything that can wait, for example, you need your gallbladder out, or you need a cataract surgery. This can wait, can be planned, and if there is a waiting list, it's okay because it's not
non-emergency cases.
Exactly. Acute care, for example, somebody comes with a very high blood sugar, what you call it, diabetes ketoacidosis, or with an acute heart attack. So this is acute care. But somebody, for example, he developed diabetes, and then you follow the patients in outpatient and try to control the diabetes. This is the non-acute care. So maybe acute care, probably we need to pay a bit more attention.
Why do you think it has not advanced or developed, this area, acute care?
Probably because, I mean, some of these other advances, people are more keen to get training and skills in because privately there is they can practice privately, and there is an incentive and income from that. And this is not a blame or criticism at all. The same applies to UK. Specialties which have a private practice is more popular because people, they do their government work and they do their private clinics. So that's maybe one of the reasons. Another reason is that maybe we need to focus more on regulating acute care and put more resources in acute care. Maybe also part of the cancer care as well. I know there are a lot of developments in cancer care in Kurdistan in the last few years. And I know one of my very good friends, I don't know whether we are allowed to name or not, he did basically, I'm aware of huge efforts, personal efforts, and also systematic, as part of the system, efforts to develop cancer care.
Is that because there's a rise in the number of cancer patients, or is it a preventative measure, or is it a beneficial field? Why is there such efforts, do you think?
I think from this colleague, I can't name it, I'm sure he wouldn't mind. He trained in France, Dr. Basak Barzinji, trained in France. I was in touch, he's a good friend. And what is good, what he learned, he came here and he started to implement it. And he gradually started to build up the cancer services brick by brick. And he continues to develop himself, he help others. So, and he assesses on what's available, how can we develop the service, provide a better care based on our resources. So that's a good practice that shows commitment to your society, to your country, and I can see the outcome from this. Whether cancer prevalence has increased or not, it's difficult to decide because we don't have very good statistics previously.
It's a good point.
Yeah, so it's possible that cancer, we live longer, and at the end, everyone has to die from something. If you live longer, you are older, it's more likely. And if you control blood pressure, glucose, you control cholesterol, you treat asthma better, you treat, for example, stomach illnesses, ulcers better, so people are not dying from complications of these diseases, then they live longer and eventually you have to die.
Exactly.
And cancer prevalence is more among people who are older. And this is one of the reasons we see a rise in cancer prevalence in Kurdistan. Another reason may be that previously many people become ill in remote villages and areas. They didn't have access to, or because of poverty, they didn't have access to healthcare. So they developed cancer, they died, nobody diagnosed the cancer.
They did not know.
They didn't know.
I've heard that, true.
Yeah, so that's
died of different reasons, which could be preventable probably.
exactly treatable at least.
Yeah.
But a third reason is that we developed financially. Look at Hawler now compared to 1990s. It's a big city. It's an international standard city. It's one of the beautiful cities. The same for Slemani. It's developed compared with previously Duhok. Last year I went and I was delighted to see all of these roads, Zakho, etc. And in all of Kurdistan, we have more factories, you have more cars, and there is
so with that development
pollution,
problems.
Yeah, maybe what I also see smoking in Kurdistan is it hasn't reduced as much as we like to see.
It may have increased.
It may have increased, yeah. So all of these also may have played in the rise. Wrong food. Before people had more, basically vegetables were cheaper. People used to eat more vegetables, less meat. Now we eat a lot of meat, less vegetables, and this is also a diet which increase the risk of certain cancers. So all of these contributes, and unless if we do a systematic study and research to follow the incidence year on year and do proper charts, etc., it's difficult to say whether the cancer prevalence increased or is it that we are better in diagnosing and treatment. We are better in treating people to live longer, and that's why the cancer increased.
I was going actually to ask you, because you set up your own research team in many fields in Kurdistan. We have the issue of the lack of data in many fields, whether it's climate change, whether it's sciences or medicine. How important is it to have research? Here, it might be just practice, doctors practicing treating patients, and in the field of research, database and studies, we might be behind. In your interactions and visits, do you think that's the case?
Yes. First of all, I have to say, before we leave the clinical side, uh, it's it's very important to acknowledge that we cannot compare our health system here with UK health system.
No, exactly.
UK health system, I'll just, if you don't mind, introducing a question, just from a budget point of view.
Yeah.
And from history, UK health system has been there for almost 80, 90 years. It is very well resourced. Its budget, UK health system, the government system, the budget is in excess of 250 billion pounds, which is around 300 to 325 billion dollars.
Wow. Yeah.
The institution I work in, Manchester University Hospitals, the budget of this institution alone is equal to the budget of all Kurdistan, maybe half of the budget of Kurdistan. It's about 2 billion pounds.
So that takes us to the point of how much of a country's healthcare budget is it important to go into the field of research? I'm sure some of that huge budget you are mentioning in the UK, some of it goes into research. Should we do the same? Do we have that here?
Yeah, I think establishing research is very, very important. And we need to focus on quality in Kurdistan more rather than just quantity. We need to produce novel projects, research rather than just basically duplicating what was done before.
Exactly.
And I think this is an area we need to resource better. We need to regulate better. And we really need to regulate academic promotions better.
What does that mean? The regulating academic promotions, promoting someone for
example,
for no reason,
for a professor chair, it has to be regulated and the
gained basically that
gained, and the standards has to be, in my opinion, has to be higher.
Mm-hmm.
Not UK standard. For example, in UK standards, to especially personal chairs, to get a chair, the standard is very, very high. But our standards here, I think it needs to be higher. I mean, sometimes I get contacted to assess promotions, and last time I apologized. I said I can't do it, because if I do the assessment, I have to assess it with the standards or near the standards of my institution, and I cannot apply this to Kurdistan.
Yeah,
there are good efforts, but I think research and academic medicine is behind is much behind in terms of progress in clinical practice.
Here,
especially in quality. We don't, for example, we don't have a recognized research center in Kurdistan that's recognized internationally. And that's not, again, it's a criticism, but we need to work on it and we need to develop it from scratch. And if we want to produce quality research, the best way is we need to link up with institutions abroad.
Yes.
Because we need to learn from them. Even my institution, my team, sometimes there are skills not available in Manchester within my team. I link up with other groups and we do work collaboratively. We learn from them. And I think we need to start like this in Kurdistan. Maybe we need to start small but quality, and then we build it up.
And the field of medicine, I assume, like any other field, it just builds on each other. You said the UK healthcare system is at least 90 years old. So something that was learned 90 years ago could still apply today. There's no disruption, right? Is it the same? Like, it has to be. The field of medicine, like other fields, should be the same. It has a history right? It's something you practice now. You might learn something from a doctor or a professor from 70 years ago.
No, exactly. So it's very important that you learn from your experience and you learn from your success and also from your mistakes.
Yeah.
And that's continuously applies. But there is no perfect system, even in UK, which in my opinion is, if not the best, one of the best systems, public systems. But there is still a lot of waste of resources. There is still a lot to improve. And every few years, the system is reshaped, reorganized. And we don't get it right all the time.
Exactly.
We don't. Sometimes we make some changes. It's a success, but on occasions it's not a success. So we need to revise and then restart and decide, was it right? Was it wrong? So we call it root analysis, to go back and analyze all the changes and decide where did we get it wrong, or was it wrong from the beginning, wrong theory, wrong proposal. So it's not just to explain to our audience in Kurdistan, no system is perfect. And you shouldn't compare systems, because systems are different in their history, in their resources, in their
Totally
experience.
agree with that.
We have to be very realistic. What we achieved so far in Kurdistan in terms of not research, but in terms of medical care, it is really delightful. When I compare it to the mid-90s, it's great.
Yeah.
We shouldn't be very critical of ourselves. At the same time, we shouldn't be arrogant. We should always be realistic. This is what we achieved. Congratulations. What can we do more?
Yes.
But please be realistic. Don't come and compare the system in Kurdistan to NHS in UK, or to the system in US, or to any other these developed countries. And just to give you an example, the system in many other European countries, especially the Eastern European countries, uh, uh, is not that different from the system in Kurdistan. Like
Yes.
public health, private care, in many Eastern European countries, the system is very similar to Kurdistan, and in a lot of even good Middle East countries, the system is not that different from Kurdistan.
And now AI has come in. Every day I hear that AI is going to be able to solve every medical problem in the future, because it has a database of 400 million cases that would analyze within seconds and tell you what's the best way. What do you think of that? Are we getting there fast, or it would take a number of years to get to a point where AI? And another point is that, as you said, we cannot compare two different healthcare systems. But since AI is now publicly available everywhere, is it time for the Kurdish medical experts here, or the healthcare system, to get on board quickly, so that this is a field, so we don't get behind everyone else like some other fields?
Yes, so AI, it's early days.
Yeah.
It would integrating AI would be helpful, and we already started, but
In the UK.
in the UK, but on a low scale. And for example, in the system, in record keeping, doing clinic letters, for example, we use dictation. We speak, and the system will turn it into a letter. And AI is used. It used to your accent. It used to your words. It used to you how do you like your letters. So AI there is helpful. In some other fields, for example, radiology, AI entered, for example, it scan, or histology, it can scan slides or radiology images, highlight the areas that needs attention, but at the end, it's a medic, it's a person who will report it. So AI in medicine would be useful, but I think the role of humans in medicine will stay the cornerstone in medical care. But AI will be helpful. Maybe it will It would help productivity as well. AI entered in, for example, in pharmacy, in shelving drugs, distributing drugs, things like that. But at the end, the person who will dispense the drug is still a person who will check it. And
It's a human dealing with another human.
Human is still the standard and still the cornerstone. So in medicine, AI role is important, it's valuable, but it still should be controlled by a human. And I think the role of AI in medicine, probably we will be more conservative adopting AI compared with other sectors.
Mm-hmm. And how about medical schools in the Kurdistan region? If you were to assess how medicine is taught in universities here, and if you were to change something, because in many cases, the Iraqi education system from the early days, which we inherited, we might have done changes in the education system in the Kurdistan region. But the Iraqi education system in general is more theories and memorization and less practice, whether you study media or you study medicine. Is that the case here? Do you think that we need to change the medical education system as well as the healthcare itself?
Yes, so medical education has developed as well, and many universities I can see, and in some I'm involved in an advisory role as much as I can. They are trying, and some of them they adopted these newer systems, these newer education systems. You are right. We need to focus a bit on clinical practice. But universities here now, they basically acknowledge that and they focus on clinical practice, not as much as we do, but also they focus on communication skills, ethical issues, medical legal issues, which are very important. So they started to adopt, but they there is we need to do a bit more. Again, there is a huge progress, huge success, but in science, in medicine, there is never stop. There is no stop point. You need to still try. Uh, Sometimes students come from Kurdistan universities to train with me for weeks. Some of them, they come and do a PhD degree. For the medical students, the ones who came, their knowledge is excellent. And the one they came, actually, their clinical knowledge was very good as well.
Yeah.
But more focus on clinical training would be good. Yeah. And without compromising the knowledge. But the standards of students is very good. And I rarely see a doctor comes from Kurdistan who fails to pass these exams to work in the system in UK.
Wow.
Some there may be delays, but rarely I see somebody who fails completely to enter the system or to let us call it requalify or take the requalification exam PLAB. Vast majority they manage to pass.
Mm-hmm.
And the medical school students, the ones I had experience with, they are very good.
So they are well prepared here, basically, in the education system.
Well prepared, and I was impressed that they were aware of the system in UK. They were aware from searching in internet, reading about the system, NHS. So I was very pleased to see this level of knowledge, enthusiasm, and the improvement in medical care. But more focus on, especially in exams, more focus on clinical questions, clinical scenarios, and more focus on clinical training and seeing patients. That would be good.
How about this might be controversial. Some doctors might want to completely disregard it, and some might see some benefit in it. Traditional medicine. What do you think as a doctor of traditional medicine? Is there any good in traditional medicine, or people always should seek the proper scientific medical advice?
First of all, I don't think I can discuss it, but I don't think I'm qualified to give a definite answer because I'm not an expert in traditional medicine. I don't have if it's regulated, I don't have objection to it in some fields, but at the end, it has to be regulated, and it does not replace medicine.
Yeah.
And it should not replace medicine. Um, even in UK, traditional medicine or Chinese medicine, for example, is still not regulated, and we still see malpractices there.
Because the people who do it are not qualified, probably.
They are not qualified. The material they use is probably not
But
appropriate.
why do some people seek, let's say, we have doctors, we have hospitals with all this technological advance. Why do you think some people would seek traditional medicine? Are they desperate or they
Even in
believe in it?
even in UK, you see patients, they say they would be happy to take capsules if it's a traditional medicine, but they don't want to take medicines. So why do they seek it? Maybe they hear some good experience from a relative or a friend, but it should not replace standard medicine, and it should be regulated. I mean, there are incidents also where traditional medicine basically it contained medicines. For example, we saw patients in UK with treated with traditional medicine with diabetic patients. Their sugar came down, but when we analyzed the capsule, there were some medicine. We call it sulfonylurea, glibenclamide in it.
So they had blended it with
blended it,
labeled it as
exactly,
traditional medicine.
and they put it with some traditional medicine and in the capsule, and they called it traditional medicine. And the patient is very pleased. It's traditional medicine. It's not a medicine, and it helped the health of blood sugar. As I said, I don't have objection, but it should not replace medicine. And every now and then you see somebody who say, "Oh, I did this traditional medicine and it helped me a lot. It sorted my problem." The problem with traditional medicine, there is no standardized quality, good research to prove that its effectiveness.
And it might have worked 1,000 years ago, but
Exactly.
not necessarily now.
Oh, it's the medicine is better now.
Exactly. Yeah, you have better options.
Yeah, some of the traditional medicine used as well. It's the same used in standard medicine. For example, in the field of high cholesterol, traditional medicines, some of them contain what we call it red yeast rice, and this is a natural statin. But it's less purified, less regulated. We don't know the dose per capsule. We don't know if batch A contains the same amount of batch B. So it's the same plant or natural statin, but the medicine, it's more regulated. You are sure that it's quality controlled. Tens of research projects shows its effectiveness. Safety is known, efficacy is known, long-term safety is known. But we don't know any of these in, for example, red yeast rice, which contains a natural statin. So this is one of the difference. Some of them is we don't know anything about it.
Exactly. And you won't be able to hold anyone accountable. For example, if someone is given some so-called traditional medicine somewhere in a dark alley, you can't hold anyone accountable.
No, exactly. Yeah.
But there's also, I would like to ask you, is some countries are known for having good doctors in a specific field. And Iraq, for example, I've had a couple surgeries on one of my knees. So, and I testify that we have good orthopedic surgeons. And the reason is that we have had years of conflict. Doctors are more experienced in dealing with bones. And do you, first of all, agree with that? Because when I showed my knee to doctors in the US and some other countries, they were really amazed by what a great job the local doctor has done for my knee. And is that true that some countries have good doctors in certain fields and some don't?
Yeah, that's true, especially countries who has a long history of conflicts, wars, etc. Uh, urgent surgical procedures or orthopedic surgery is developed well, and doctors, instead of doing one or two operation per week, for example, knee replacement or knee surgery, they do 10, maybe in Kurdistan. So their skill develops, their practical skills develops faster. They need to make sure they adopt new techniques, but that's what you pointed out. That's true.
Yeah. So the types of cases in the country decides what the doctors would be good at.
Yeah, exactly.
What kind of disease is prevalent, or whether it's to do with bones or anything else.
Yeah, exactly. Especially diseases that involves procedures, for example, surgery. That's very good. For medicine, it's a mix, knowledge and clinical experience, plus what medicines you have available to you. But with surgery, uh, clinical practice and doing more surgery is more important, and that explains your experience.
Yes.
And we have very, as I said, our doctors and surgeons are very knowledgeable. Our surgeons, they perform complex surgeries. I saw patients who had complex surgeries with success, challenging cases.
Kurdish surgeons,
Kurdish surgeons in Kurdistan with huge success. My message is that the skills are good, but when you use, for example, material or joints, for example, material to fix the joints, etc., please make sure you use the standard ones, the quality ones from validated and trusted sources, rather than some other sources which are not validated, or they are not as good as the original tools, techniques, material, or joints. So please don't compromise on the quality of the material you use, because if you do this, that will compromise the outcome and it might affect your success.
Exactly, and lose people's trust in the field in general.
Exactly. So you have to, especially if you practice the broad learned skills in UK or in other countries, you come here, you have to follow the same standards to keep the success.
Okay, one question, which could be the last point in our discussion, is spending time in nature. Last night, I saw a post that said if you spend time in nature, if you run and go hiking in places, it reduces medical issues by, I don't know how many percent, I forgot the exact number. And this may have to do also with your field, how important it is for people to not just seek medicine and all that, rather to be active and go to the mountains. Here we have enough mountains and nature around us.
Yeah, that's a very good point. This is a part of prevention. Healthcare is not only the doctor's responsibility, is also the patient's responsibility, the general public's responsibility. You have to look after your body, so your body looks after you. So walking in nature, doing regular exercise, avoiding weight gain. If you're overweight, lose weight. Please don't smoke. Alcohol drinking, please, within the safe limit, for example, which is 14 units per week. Try not to exceed. Eat more vegetables, less meat. I'm not a vegetarian and I eat meat, but to be honest, twice a week, unless if I'm in Kurdistan, because the meat here tastes very good.
Exactly.
But you have to look after yourself, because we call it lifestyle modification or control.
Yeah.
You have to do all of these things you mentioned, so your body remains healthy. And if you notice some, and after age of 40, you have to have regular health checks, blood pressure, blood sugar. And if you notice something is not right, seek medical advice. everything is easier to treat early rather than late.
That's
And there are some evidence that doing exercise, losing weight, it helps to reduce the risk of, for example, losing 10% of body weight if you are obese or overweight, reduce the risk of diabetes by around 10%, blood pressure, reduce the blood pressure by around 10%, reduce cholesterol by around 5 to 10%, and uh, obesity, which is a major health issue, uh, it's not a risk only for diabetes, heart attacks, strokes. It's also a risk for cancer. If obese patients are more likely to develop cancer, and of course, as you mentioned, exercise, but smoking as well. Please try not to smoke.
Mm.
And if you're a smoker, please stop. And vaping and nargila is as bad. If you can, avoid these as well.
Exactly. So that was really enjoyable, very eye-opening, I must say. I personally learned a lot from you, Dr. Handrean Soran. Really appreciate you coming to Erbil Edition today and sharing with us your knowledge and experience.
Thank you very much for hosting me. And again, thank you for the team
Thank you
in
very
Erbil
much.
Edition. Thank you.
You.